Good morning and welcome, everyone. So good to have you in person, so good to be here with you in person. And I also welcome our guests who are on the line, taking this research day virtually. My name is Vasanthi Srinivasan, and I lead the OSU, the Ontario Sport Support Unit efforts in Ontario. I'd like to begin the program with an acknowledgement of the land we live and work on. We acknowledge that OSU is located on the land we now call Toronto, and that OSU operates across Toronto, which is home to many diverse First Nations, Métis, and Inuit people from across Turtle Island. Toronto is on the traditional territory of nations including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, and the Haudenosaunee, and the Wendat peoples. It's also covered by Treaty 13, signed with the Mississaugas of the Credit. We're deeply grateful to the generations of people, past and present, who have tended this land and acknowledged the abiding wisdom of the Dish with One Spoon Treaty between the Anishinaabe and Haudenosaunee to share and care for it. As settlers, we're thankful for the opportunity and privilege to meet and work here. We seek to move forward with humility, respect, gratitude, and meaningful relationship building. So we are here and we're starting the program with a slight difference from what you might have, because I'll be introducing the deputy who will speak, and then she has to run off to another meeting, the life of a deputy. I'm now very pleased to introduce Dr. Catherine Zahn, Deputy Minister of Health, who will make some opening remarks. Dr. Zahn became deputy in September 2021. She previously served as President and CEO of the Center for Addictions and Mental Health, CAMH, from 2009 to 2021. Throughout her career, Catherine has worked to promote equitable access to health care for Ontarians, including those with mental illness. She has made numerous contributions through her leadership in hospital integration, technology assessment, chronic disease management, stroke care and coordination, mental health and care systems. We're most fortunate to have Catherine, I call her my friend, as Deputy of the Ministry of Health at this very critical time. So over to you, Deputy. Wonderful to see you.
Thank you so much, Vasanthi. It's so wonderful to see you. I'm so sorry that I couldn't be with you in person this morning, and really appreciate your accommodation of me to speak early on the agenda. As Vasanthi pointed out, I'm now the Deputy Minister of Health for Ontario, but I've actually worked in the healthcare system since I was 16 years old. I have no other work experience, and over these years I've learned so much. I've had so many experiences at many levels of healthcare that I'm also very grateful to have this job as Deputy Minister of Health as a bookend to my career. It's given me a whole new perspective and a whole new understanding of what our opportunities are, and what we have to look forward to in the future. So those of you who are familiar with my work will know that I'm deeply committed to research across the entire spectrum, from fundamental science to health system studies. I think our future as individuals, as populations, as a healthcare system depends on it. And I've had the opportunity, as you heard from Vasanthi, to interact with SPORE, the Strategy for Patient-Oriented Research, since its inception. And I'm really proud to continue to support a collaboration with OSU in advancing patient-centered research. Just as a start, your policy roundtables are a great illustration of the importance and impact of the work. to me, the special value is the opportunity for researchers to interact not only with government leaders, but other key partners for the most rich and strong discussions that lead to a more durable commitment. Again, those of you who know me and my work at CAMH will also understand my commitment to patient and community involvement in research. That value accrues especially when partners are involved at the front end, helping our researchers understand the questions that are interesting and important to them, and not having that involvement occur just as an afterthought. This upfront involvement of all stakeholders can only lead to positive experiences and outcomes, to stronger health care delivery, and more robust health systems. So again, thank you for your many contributions to creating new knowledge, using that new knowledge to innovate, and applying it for positive change. As researchers, patients, healthcare providers, or policymakers, you've all had a strong hand in shaping healthcare in the past, and I trust that you're turning your attention to the many issues of today and tomorrow. Now, Ontario is committed to supporting education and knowledge exchange toward promoting evidence-based decision-making. I believe that we share a goal of a learning health system, which essentially is one that continually evolves and improves to meet the needs of our citizens. Your aims to engage and connect with patients, to enhance research and accelerate knowledge translation are very tightly aligned with the ministry's priorities that are detailed in the Your Health Act, which is easily available online. And I'll tell you that Ontario maintains a commitment to supplement federal funding, increasing the impact of the strategy for patient-oriented research and to supporting OSU's projects. There are so many examples of the impact of our joint research efforts. One that's come to my attention recently is the use of healthcare system navigators to assist Francophone patients in accessing health services. This is a model that will be extended to other populations across Ontario whose first language is not English. This partnership has also led to the design and delivery of specialized training to put patient-oriented evidence in practice. So together, we've enabled senior decision makers at the Ministries of Health and Long-Term Care to support their choices with patient-informed evidence. Again, collaboration for innovation and knowledge sharing is a touchstone for an integrated, accessible, and responsive healthcare system for Ontario. I think your agenda today looks very rich with esteemed speakers and panelists who will be sharing their insights on patient experience and learning health systems amongst other key topics. So I very much look forward to seeing how the work evolves. And I thank you very much for your dedication to healthcare and for your many contributions locally and globally today and tomorrow. Thank you.
I thank you very much there, Dr. Zahn, for imparting your knowledge and experience on us this morning, and with taking time out of your very busy schedule. I believe you have a meeting at 9:30 to get to, so thank you very much for taking a bit of time and speaking to us today. So welcome, everybody, to OSU Research Day 2023. It's good to see some familiar faces and in person. My name is Dean Ferguson. I'm really pleased to serve as the scientific lead for OSU, the Ontario Spore Support Unit, and I'll be your Masters of Ceremonies today and shepherding everybody along and hopefully on time. We'll start with a few housekeeping activities. The first is the QR code on your table has both the survey but also the detailed program. So OSU is going green and trying to cut down on the amount of paper. And so use the QR code. We will be on Twitter, or X, I guess, formerly known as Twitter today, and we also encourage you to engage with the X community. And our hashtag is hashtag OSU, OSSU, OSU Research Day 2023. We also have a live chat box for you, everyone online, so feel free to say hello, and but also important that any questions, please use the chat box and we will get those to the panelists and speakers. And for those that we don't get to, we will be passing on to the panelists and speakers so they can follow up with you. For us attending the event, the washrooms are just outside the doors here. And for those that aren't, I can't really help you. But, and finally, all the session, the entire day is going to be videotaped, and we'll make that available at the conclusion of today and place it on our OSU website. So before we begin the program, I'd like to invite Frank Gavin, who is the chair of the Ontario Sports Boat Unit Board of Directors, and he's going to share a few words. Welcome, Frank.
Thank you, Dean, and good morning, everyone, here in person and online. I had cataract surgery a little while back, so I'm in that stage of not knowing whether to wear them or not, but I need them. So thank you, health system, for giving me better vision and complicating my life. So I'm delighted on behalf of the board to welcome all of you to this 2023 Research Day. Before we begin, I'd like to tell you a little bit about OSU. OSU has two mandates: to transform health research and health services research through a variety of patient-oriented approaches, and to support the uptake of the evidence that emerges from this research. The two are closely linked and equally important. Since it began in 2014, OSU has pursued its mandates by bringing together patients, and I would say some members of the public who may not always think of themselves as patients, and researchers, along with policymakers, decision makers, clinicians, and others, to develop highly relevant patient-oriented research evidence that will improve the health and healthcare of Ontarians. This collaboration will help us all achieve the quintuple aims: improving people's health, improving patients' experience of care, improving the well-being of healthcare providers, advancing health equity, and reducing costs. So OSU helps to bridge the gap between research evidence and healthcare policy and practice by providing services to meet the patient-oriented research needs of the health system stakeholders, strengthening and maintaining Canadian capacity to conduct and apply patient-oriented research, and engaging patients, researchers, policy and decision makers, clinicians, and others partners in both patient-oriented research and the implementation of its results to improve the health care of all Canadians. With this in mind, OSU is looking forward to continuing to deliver on its two mandates in the coming 3 years. Today's program features presentations that we hope you will find not only interesting but inspiring on topics such as how data collection and analysis are helping to shape a better healthcare system for Ontario, what progress is being made in creating an Ontario learning health system, how patient and family engagement is strengthening child health research, and how patients have actually experienced being engaged in this research. All of these sessions include speakers who are researchers, some established, which I think is a euphemism for older, some early in their careers, and some trainees. And speakers who are patient partners making indispensable contributions to the work of health research. So now I'd like to call on Dean again, and then we'll be concluding this introductory part shortly. Thank you.
Good. So the good thing is we're a bit ahead of time right now, but it's now my pleasure to introduce the moderator of the next session, which is the Healthy Debate Live, talking about the power of data linkage and all the great things that have happened in this province. I'm pleased to introduce the moderator, Dr. Seema Marwah. Dr. Marwah is probably known to many of you, but for those who may not, she's a general internal medicine physician at St. Mike's Hospital, as well as the editor-in-chief of Healthy Debate. And so without further ado, I'll welcome Dr. Seema Marwah, and she's going to introduce the panel and moderate the next session. Thank you. Seema.
Hi, everybody. How's everybody doing today? Everyone's had their coffee? Yeah? I'm so excited to be here in person and virtually. I think that's so wonderful. It's been, what, 3 years? Right? I see some nods. So as you've heard, I'm the editor-in-chief of healthydebate.ca, and we're a health publication that publishes a lot on health research and health policy, started by Andreas Lapakis, who many of you guys know. And I'm very excited to moderate what promises to be a very thought-provoking and future-thinking session on data. So this is obviously a huge topic of discussion, and in the 75 minutes that we have, we can't cover everything. So we're gonna narrow on data enabling community-engaged research and helping us to understand and identify health inequities. So we want you to leave this session understanding the power of data linkage when used responsibly. But we also have a very esteemed group of panel experts who are gonna help us with this challenge. So, in our 75 minutes, we have a lot to pack in. So the way this is gonna work is I'll introduce each of our panelists one at a time. We have 3 people who are here in person and 2 that are attending virtually. They'll come up to the podium and give us, a 5-minute talk from their lens. And then for the second half of the panel, which will be about 35 minutes, we'll open up to questions from the in-person audience, but also virtually as well. So I think, we have a lot to pack in, so let's get started. So our first panelist who's gonna come up to the podium is Charles Victor. So he's the Senior Director for Strategic Partnerships and Digital Services for ICES. He's gonna give us a quick overview of the development of the OSU data platform and highlight its potential to enable community-engaged research in the future. So please welcome Charles.
Thank you, Seema. It's my pleasure to be here today to give a bit of an overview of the OSU data platform, past, how it was developed, and also future, where we're going. All right, I thought I had this down. So we'll talk a bit about key accomplishments. Here we go. So in 2014, now unfortunately both of these are very small and I can't see either. I may choose to sit down, is that okay? My age is affecting me as well. So in 2014, as you know, we started the OSU data platform, started with data and analytics services. This was the first time that we really opened up the ICS data repository to third-party researchers, so researchers not affiliated with the Institute. And this was a huge advancement in Ontario for access to data. I came from the university and I used to be one of those researchers that was like, they just hold on to that data. But the data became available. In 2017, we expanded services starting to enable linkage of external data into ICS so researchers could bring in their own data and follow up patients and participants in studies. In 2018, ICS developed or instituted its Public Advisory Council. And in 2019, the data platform formally became part of the Health Data Research Network, which is a CIHR SPORE-funded network of like centers across Canada. In 2021, we expanded our services to enable artificial intelligence and machine learning research capabilities. But really, what we're here today to talk about is what is the future. And over the next year and a half, we will be working with the Information and Privacy Commissioner of Ontario to enable ICS to operationalize the collection and use of intersectoral data. Data that will, when linked with the health data, will enable incredible research into the social determinants of health. This includes data on social services, housing, transportation, justice, etc. So we've seen a steady growth in the use of our data and analytic services over the course of the OSU period. We have, I apologize, it's embarrassing. Yeah, there is a pattern. You know, we enabled remote access to researchers across Ontario, 40% of which come from outside of the GTA, so really opening up access to the data. Where we started with 14 active projects in 2014, we now have over 100 active projects each year and have completed over 1,000 requests since 2014. So a huge amount of research using the data and analytics services. And while in 2014 we started by enabling access to about 33 research data sets, now Ontario researchers have access to over 76 data resources. So for us, the 1,000 projects was a big event. This happened just this past year, so we highlighted that. And these projects result in high impact research. This particular project, many of our the projects that are conducted through data and analytics services do quite well. They reach high impact journals with broad reach. This particular project, the researcher was so thrilled that they made the top 25 most read articles for this research during COVID. But the OSU data platform doesn't support just our third-party researchers. Really, it's about many different clients and stakeholders. We have knowledge users, such as health system stakeholders, communities that we are enabling access to the data, and of course, our ICS scientists, many of whom work on SPORE-funded research, SPORE-funded clinical trials, etc. And the breadth of data that we have continues to grow. In particular, on the rightmost column, you'll see the intersectoral data, and this is what we want to focus on today, is how do we enable research on communities that otherwise haven't been able to be examined with the data. And part of that is through integration with novel data sources. So where do we go from here? Community engaged research. Now this is not something that is new. OSU has fostered community engaged research from the beginning. In phase 1, there was a focus on Indigenous data sovereignty and support for Indigenous communities. ICS has developed data governance agreements with several Indigenous governance organizations, and those continue to be in effect and result in research that supports community. As you'll hear later on, OSU also had a focus on sex and gender, Francophone health and language, and in phase 2, a renewed focus on equity, diversity, and inclusion. Just a couple examples of the types of research that we're trying to enable. You'll see that I've listed a couple of requests that are supported by community, whether that community is our Public Advisory Council that has posed a question and is involved in developing the research question, interpreting the research results. We have the Black Health Equity Group as an example, who is supporting us in answering questions around health access for Black Ontarians. Similarly, we have brought in data from the transgender community from 4 clinics across Ontario to help support research looking at health access for transgendered individuals. these are just 3 of the examples that I wanted to highlight as where we're going. And my last comment, these resources are available on the internet. And in 2021, ICS held the People's Panel, which informed a guiding document that sets out a framework for equitable research. And the second pillar in this framework is community access. And so I think that's where we want to focus the rest of the talk.
Thank you very much for that. I think, data access then and now, and it was a wonderful overview and could not have been a better segue to our next speaker, who's joining us virtually. Her name is Dr. Jennifer Walker. She's a Haudenosaunee member of the Six Nations of the Grand River, a health services researcher, and a core scientist and Indigenous health lead at ICES. She is speaking to us today about engaging Indigenous communities in data-intensive research, and again, joins us virtually.
Good morning. It's really nice to be here with you virtually. I wish I was seeing you all in person. I just want to acknowledge I'm speaking to you from the Dish with One Spoon Treaty area. I live and work in Hamilton, Ontario. And I'm Haudenosaunee, a member of the Six Nations of the Grand River, and a member of the Wolf Clan. So I wanted to chat a little bit. We have these brief presentations, and then we'll have a chance to chat more and answer questions and bring the pieces together. But specifically around the development of Indigenous data platforms in Ontario, and thinking about the current state of those platforms, how far they've come since that sort of 2014 timeframe that Charles was talking about. And then what is the future of those? Which groups are we currently missing which voices are we currently missing from those Indigenous data platforms? And which data are we potentially missing from the health and healthcare experiences of First Nations, Inuit, and Métis people in Ontario? So there's still a lot of questions. So I guess I want to convey that this is a long journey, a long road, and we've come a long way on that road, but there's still many, many things that we need to consider, and we need to continue to grow. But in terms of the sort of involvement and engagement in the building of platforms, so we've done a lot of work both to build the platforms, because that work can't be done without Indigenous communities, Indigenous leadership support, and that strong Indigenous governance that must be there when we are using or thinking about Indigenous data in the context of these platforms. So building the platforms, and then also using the platforms and refining them through conducting research. So you notice that I'm using the plural here because we have this sort of foundational platform, but we have multiple Indigenous data platforms that, because of the diversity of governance of Indigenous, of the sort of existing Indigenous governance structures, the First Nations structures, Inuit and Métis governance of affairs of each of those nations in Ontario, which then gets reflected in how the data can be governed, how it can be collected, how it can be used, how it can be accessed. So there are some pretty formal structures at ICES for the access to the data platforms that have been built. So there are formal data governance agreements with Chiefs of Ontario that help to provide access for First Nations to data to their own data, but also provide protection to ensure that the work is being done in ways that honor the perspectives, knowledges, and governance of First Nations. So Chiefs of Ontario and Grand Council Treaty 3 and Kenora Chiefs Advisory. So we have these formal data governance that pertain to First Nations data. We also have formal data governance agreement and partnership agreement with the Métis Nation of Ontario, and then which has allowed for the linkage with the Métis Citizenship Registry in Ontario. So these governance agreements both create the data platforms, they allow for the linkage to the citizens of those nations, and then they also apply to how the data are accessed and used. And so really one of the things I want to sort of, this is the platforms we have right now. And one of the things I sort of want to leave you with is this this acknowledgement that it's not just that it's nice to engage Indigenous people in the use of their data. It's actually a requirement of the Tri-Council policy statement, which says that researchers shall seek engagement with the relevant community where the research is likely to affect the welfare of an Indigenous community or communities. And so this includes research in which Indigenous identity or membership in Indigenous community is used as a variable for the purpose of analysis of research data. So we really, like foundationally, we have Indigenous principles around data governance, like the OCAP principles and the CARE principles, et cetera. We also have clear guidance for research ethics in Canada that says that if we're using Indigenous identity in an analysis, then engagement is actually required. So we have tools and pathways. We've had lots of work on changing policy, changing the way that these projects are done within ICES to enable these strong principles and ethical requirements to be met. So rather than creating barriers, they really create pathways to ethical community engagement and research. There's so many things I'd like to tell you, so many stories I'd like to tell you, but I'll save it for our fuller discussion in the interest of making sure that everyone has a chance for their time. Thank you very much for listening.
Thanks so much, Dr. Walker. So our next speaker, so we're going to introduce the panelists one at a time, and then we'll have the discussion after. So I want everyone to write down the questions that they have, because we'll have time for a fulsome discussion after all of our panelists have been introduced. So Dr. Paula Rochon is the founding director of Women's Age Lab. She's a professor and RTO/ERO chair in geriatric medicine at the University of Toronto. And she's going to briefly discuss addressing age, sex, and gender disparities in health data research. So I'd like to welcome to the podium Dr. Rochon. And you have your choice of the podium or the chair.
So I think I'll start here. So thank you so much for the introduction. I'm a geriatrician and somebody who's very interested in improving health and well-being for older adults, especially for women, older women, who I think are really a missed population in a lot of the research that we do. And, you know, a group that a lot of people feel are really quite invisible. Now, let's just see if this works. Okay, that's the first slide, right? So in Ontario, we have, I think, amazing population level data with, you know, more than 2.5 million people who are older adults. But I think we can use these data better, especially when it gets to looking at issues related to older people and women. Because, you know, we have variables, at least in my experience, basic variables like sex and age, it's clearly in the ICES database. But those variables are available in virtually every kind of administrative data sets that you might want to look at. But I don't think they're used well enough to get at the issues we need to look at. So if we don't look for differences between people by age and by sex, they get completely missed. So this is something that I think we need to do better, and that's going to be the focus of what I want to talk about today. So I see what you're saying about you can't see the slides. That's very true. Okay, and it's good that we all have glasses on for whatever they do. So this is an example on the slide of where where we're looking at type 2 diabetes. Did I go forward? There, okay. So if you look at the picture there on the slide, it's looking at type 2 diabetes, and it's looking at information of people who are newly diagnosed with type 2 diabetes by age and by sex. And so what I'd like to point out to you is, as you get older, the diagnosis of type 2 diabetes increases. So you kind of see that increasing trend in the data that we're showing there. And especially when you start at the age of 50, which is considered older, so just so everyone knows that, older, it starts to increase further. But also look at the sex difference. So you can see that I think the blue is men and the males, and the brownish color is females. You'll see that there's a difference between males and females throughout that perhaps get a little bit more pronounced when people get older. Interestingly, it's males across the different age groups that are more likely to develop this condition, which is unusual because most chronic conditions are more common in women than in men. But if you don't look for these kinds of differences, you don't really see this kind of pattern. And it speaks to the importance of having data presented disaggregated both by sex and age if you want to understand what some of the unique needs might be for women and men. So this increase in chronic conditions with age is something we'll see with a lot of different conditions, things like dementia, things like osteoporosis, things like arthritis, although in all of those conditions, they'll predominantly be women that are more likely to experience those. So as part of the work that we've done here over the years with OSU, we created a module that's called What Gets Counted Counts. And it's a whole module that is helping people to think about the importance of looking at sex and age disaggregated data, and to help researchers who are just junior in their career think about it. But I must say, I think it's something that all researchers need to think about, and even more experienced researchers don't necessarily look at this or think about this in their research, and it's something that's pretty easy to do. So this module was created by Robin Mason, a Women's Age Lab scientist, along with Joyce Lee, who's the research lead for Women's Age Lab. And it was interesting also in that it involved OSU patient partners. They helped to inform the development of this module, which I can't sort of underline how important that is to get the patient perspective and what they think is important included. So that was really, really good. In addition to that, the patient partners also created a webinar where they actually used this module and brought it out to other patient partners so they too could see what the potential importance is of it. And I do think one of the things that this module does is it does show the importance of thinking about sex and age disaggregated data. That fits with the idea of the sex and gender-based analysis plus that we're encouraging people to do in all of the research they do, that CIHR is requiring as part of their grant process, but something that we just don't do well enough. So I think this is an invaluable resource that you might want to think of looking at, and hopefully lead you with the idea, even in all the work that we do, to think about disaggregating data by sex and age as the very starting point to start looking at important differences so that ultimately we're getting information about older adults and particularly older women that currently we don't get. Thank you.
Okay, so far, in terms of data, we've heard three perspectives, one very much about infrastructure, one about Indigenous partnerships, and now we've heard about disaggregating data by age and sex. So for our next speaker, I would like to introduce Dr. Peter Tenusteputro. He's a public health and preventative medicine physician, a family physician, and a health services researcher as well. And he'll be speaking to us about his work understanding the impact of patient language on access to care. So welcome, Peter.
clicker?
Yeah, that's pretty small.
Up to you.
Okay, I'm gonna go
Choose
over
now.
there. Hi, everyone. Okay, so I'm gonna talk about language. Thank you for having me here today. Again, I'm a public health physician. I practice as a family doctor, but I mainly do health services research using data at ICES. And why am I talking about language? Well, this is something that came to our desk from the Institut Savoie du Montfort, which is a French hospital or the research institute that's associated to the French hospital in Ottawa. And they had a desire to build a program of research that looks at the disparities in language and health and healthcare outcomes for francophones and allophones as well. So I'm gonna give you a snapshot of a few of the things that we've done so far. Okay, so just a little bit about me. Mojokerto, this is where I was raised. I was born in Surabaya, but then lived in Mojokerto for 8 years. I shouldn't have put the date of my birth, but that ages me. Anyone know where Mojokerto is or Surabaya? Any guesses? Indonesia, yeah, exactly. That's why my last name is so weird. It's supposed to be Tan, but Saputra means son of Tan, but everyone thinks it's Greek or something else, but yeah, it's actually Indonesian. And, I just have vivid memories. This is a picture actually in 2023 of Mojokerto, and when I grew up, it was much less developed. And I still remember walking down the street, ordering satay ayam, which is, chicken satay. And, it just had such a profound effect on who I am now. My first language was Bahasa Indonesia. We immigrated in 1986 to Canada, and none of us knew English. It was quite shocking. And I still remember, I was learning English in grade 3. They tried to teach me French at the same time, but then they gave up. It's like, let's just teach them English first, and then let's see what happens. So it's kind of weird that I'm leading this program of research on francophones, because everyone speaks, English, just for me. And I'm running out of time, so I'm gonna keep on going. Okay, so language as a health determinant. So I say that it's forgotten because often we don't use language as a variable, in our analysis, right? And 29%, so I'm one of the 29% of Canadians that neither have English or French as their mother tongue. And, we all know this. I think this is all given that language is important in medicine, in diagnosis, treatment plans, building rapport, supportive counseling. But it's also a reflection of people's culture, right? So it's a reflection of their values and beliefs, their goals of care. And I do a lot of research, just like Paula, on older adults, and including those in long-term care. And in long-term care, it's not just health, right? It's health and care, right? And it's health and, long-term care is a home. And, and when we provide care to these individuals, we have to, be very careful or be mindful that they have very specific needs, not just for their health, but also for their living needs. So, so this is what we've done. So we've looked at language and language concordance, essentially. So language, people don't realize, I'm going to show you the next slide, but there's about 21 or 25 databases at ICS that contain language, including the home care and long-term care databases that we use quite a bit through the RAI assessments. So we look at the language of the patient. We've also linked, and this is really, really eye-opening, we linked CPSO data, so CPSO, the College of Physicians and Surgeons of Ontario data for all physicians in Ontario, and we linked that data to ICS so that we're able to know what languages the physician speaks as well. So now we can look at the concordance between patient language and physician language, right, through their OHIP encounters. And we look at language not only, of the patient, but language of the physicians, and whether or not language concordance makes a difference. And I'll show you here, that it does quite make a difference. We also look at the facility language. So I told you long-term care homes, for example, some of them, are mainly French, or some of them are ethnic specific, like Chinese. And we look at whether, living in a long-term care home that is specific to your culture, whether that makes a difference as well. Okay, so I'm not gonna go through this. 25 databases in ICS. This is a repository of all those databases. So we did this work initially, and we start looking at health disparities. Okay, so this is long-term care homes, long-term care residents, and these are the 6, or 1, 2, 3, 4, 5, 6, yeah, 6 quality indicators in long-term care that are commonly reported. And we looked at francophones, and we looked at whether or not they were cared in a French-designated or bilingual designated home versus a non-designated home. And you can tell there that those francophones who are treated in a designated home had lower rates of antipsychotic medication, lower rates of depression, pressure ulcers, interesting higher rates of pain. And we think maybe that's because they can communicate their pain better to the providers, and higher rates of falls in non-designated homes. So that's long-term care. I'm going to show you something even more striking. I know I already only have 1 more minute, but this is a CMHA paper that we published last year looking at patients who were hospitalized, okay, admitted. And we looked at francophones and allophones. Allophones are people who don't speak English or French. And we look at the language concordance between the patient and the physician, the treating physician. And the first outcome there in A is inpatient harm. So those are like falls, medication errors, surgical infections, things that could be potentially prevented. And you can look at the adjusted odds ratios for francophones. If you had a physician that speaks the same language as you, 37% lower odds of having one of these harms, 75% lower odds of having harms, 75% if you're an allophone being treated by a physician who speaks the same language as you. Length of stay not too different, but look at in-hospital mortality. Okay, what is that? I should know. 31%, okay. 31% lower odds of dying, okay? It's black and white if your physician spoke the same language as you, if you're a francophone, and 56% lower odds of dying if you are an allophone and your physician speaks the same language as you. I think anecdotally we kind of know all of this, that it makes a difference, but if I told you I can give you a pill that lowers your chance of dying by 50%, like who's not gonna take that pill, right? And do we go all out to try to provide care that's language concordant? No, it's pretty rare, huh? Like sometimes you're too busy, sometimes there are people who can't speak, translation services are a bother, so this kind of highlights that it's really as important as any other intervention that you can do in medicine. Okay, I'm out of time, so I think I'm gonna stop there, and we have other slides, but basically the conclusion is that language is often forgotten, and it shouldn't be, right? It's one of those health determinants that really make a difference, not just because for communication, but for culture and all the things that make a person a person.
So we're actually keeping very well to time. So I am going to introduce our last speaker who's joining us virtually. So it's Dr. Arjuman Siddiqui, who many of us know. She's a professor and Canada Research Chair in Population Health Equity at the Dalai Lama School of Public Health. And as I mentioned, she joins us virtually to discuss the importance of identifying and evaluating the impact of social determinants of health. Welcome, Arjuman.
Thank you so much. Thanks so much. So I don't know how well my presentation corresponds to the title that I might have given months ago, but let's give it a shot. I am, as some of you may know, an epidemiologist, and I was trained in the US. And so my perspective on data analysis and the landscape of research for health inequities is actually quite different than what I see in Canada. And so I thought I would sort of offer you some perspectives from the international world of this research, and let's see where we get. Next slide, please. Next slide, please. Thank you. So this is just a familiar framework. This is the WHO framework on social determinants of health, but arguably it's just a framework on all health. And if you start on the right-hand side with health outcomes, they are produced by a variety of mechanisms, ranging from healthcare access to living conditions to behaviors to physiological stress and so on. And as we kind of all probably know and operate on the assumption of, those pathways are very much linked to your social position in society, what we often call social determinants of health, your income, your education, your race, ethnicity, and so on, and gender, and many of the other variables that the panel has talked about. And that all of that tends to be orchestrated by a bunch of societal factors like policies that set up the conditions under which these relationships exist. So if you stare at this framework, you can see why linked data would be important, right? So the first thing is we would want linked data because we'd want the ability to study any and all of this and the myriad of ways that this is expressed. And we'd want to do it for large populations so that we can get some generalizable results. We'd have large samples and so on and so forth. Now, I want to come to the issue of community partnered research and non-community partnered research, which I see as one of the really important distinctions in terms of where Canada is and where the international community kind of sits. So if you stare at this framework, you can definitely see the merits of doing community partnered research, community-based research, et cetera. You can imagine all the ways, as I think Professor Walker eloquently said, you know, if research affects communities, you can imagine that you'd want research to be engaging those communities. But I submit to you that there is also another way to look at this, and that is that this framework tells us that there is some fundamental science that can also occur on health equity that is perhaps not ready for rollout to communities, that perhaps isn't in the domain of partnered research. And I want to give you some examples on which we all draw in the health equity world that hasn't been partnered research. And if someone can do a chime check for me, I've totally lost track. Next slide, please.
You're good.
Okay, great, thanks. So this is a picture of W.E.B. Du Bois, who some of you may know is the father of all sociology. He was a scholar in the United States, and he, next slide, please, had done a ton of work to document the state of Black people in the United States during the time of slavery and beyond. And he is well known for a set of graphical depictions he made using census and other data to portray what was happening to Black people. And he is really considered one of the foundational theorists, the foundational empiricists in the field. And this was not partnered research. This was a scholar who knew, had a lot of depth of knowledge in the social science. You can argue that he had personal experience, but then again, we kind of get into what is community. But he produced some very important insights on which we all draw that was not partnered. Next slide, please. This is a slide of a potpourri of major, major health equity scholars on which we all draw. And by and large, their work is using big data, like data linkage, linked data, or other administrative data, or survey data, to try to understand health equity. In the top left-hand corner, David Williams, one of the major race and health scholars. In the middle, Nancy Krieger, ditto for all health equity. Sherman James on the right of Nancy, and below, Zinzi Bailey, an up-and-coming race, racism, and health scholar. Ana Diaz-Rue, who does a lot of neighborhoods research, and Amani Allen on the bottom right there, who does a lot of work on Black women's health, particularly in relation to social determinants, racism, and stress. Again, these are not scholars who, by and large, are using community-engaged research, but they are producing some phenomenal, basic, fundamental science on health equity. And next slide, please. So this leads me to some provocations. So the first is that it is absolutely the case that many, maybe most of the main contributions of our time to understand social determinants of health internationally, the literature on which we draw, and to understand health inequities using large data sets, has been made without community engagement. Why is that? How did that come to be? We can talk about this, but I think one of the main reasons is that this was considered fundamental science as opposed to applied science. The second, will Canada concede that there is room for work in this area that is community-led, driven, and partnered, and that there's room for work that isn't because it's not actually ready for translation, or it's so terribly politically sensitive, as I have experienced trying to do partner research, that it's very difficult for communities and policymakers, and arguably not desirable for them to get involved in this research. Or is Canada staking a claim for another path, which is that everything should be partnered irrespective of what it is, and everything is ready for so-called knowledge translation, and that there's really no value in scientific questions in and of themselves that don't have partnerships? And if that's the claim we are sort of staking, then the question is, are we ready for the implications of that? Because there are implications of that. And so I think in the end of the day, where I fall on this is that we should be sort of deliberate and very cognizant of our choices and understand that as wonderful as community engagement can be, that if you look at the larger landscape, you may sort of see that it doesn't necessarily behoove us to have everything be community engaged for the protection of the science, but also for the protection of communities. And I'm totally happy to talk more about this. Thank you.
Can we just have one more round of applause for all 5 of our speakers? And also, I want to thank you guys for keeping to time, because we have a good 35 minutes for a Q&A. How the Q&A is going to work is virtually. You can put questions in the chat of the live stream, and I have them right in front of me so I can address them in real time. I also see a microphone at the back, so if anyone in the room would like to ask a question, we can also circulate one of these mics not being used as well, so just put up your hand. And then I, as the moderator, have some questions as well that I'll make sure I get answered. And then I think to make it easier to involve our virtual participants, is it possible to get both of them up on the screen at the same time? And then I'll do my best to throw to you guys directly so you can feel involved, but also just raise your hand either digitally or in person if you would like to chime in as well. So we have Dr. Siddiqui. Do we have Dr. Walker up there? Okay, well, I'm going to start with the first question. Now we got them both. Okay, great. And then I'm going to stay up here so I can see everybody. So the first question that was submitted in advance is for Charles. And so one of the goals of this session is to help us understand the power of data linkages when used responsibly, emphasis on the word responsibly. And the creation of the OSU data platform is a success story, like we talked about. But what are the concerns we should be aware of when creating and using such platforms? And what do you actually define as responsible use?
So I think first and foremost, one of the challenges with the data platforms such as they currently exist today is the accessibility to data that defines community. And what is community? You know, is community a condition? Is it a geographic area? Is it a race? And where is there intersections in community? The challenge is we have great data on, you know, what your condition is, or what was billed when you went into the doctor's office. We don't have great data on, you know, race or social well-being. So I think the challenge there is understanding the limitations around the data that's available, understanding where there's data available, and Peter alluded to that, you know, often there's data available that we may not know about. But when you find that data, or if you bring that data in, assessing the quality of the data, because the worst thing that we want to do is introduce bias and therefore harm by having data that's not of sufficient quality You know, we do have some databases, for example, that contain, you know, racial identifiers, but the quality isn't terribly great, and so there has to be considerable caution in using those data. And so having a framework around that, having quality checks, and ensuring that, you know, researchers just don't blindly use data that seems to be available to them.
Thank you very much. Do any of the panelists have anything they'd like to add? Just saying no. Okay, we'll move on to the next question. So the next question's for Jennifer. So you had mentioned that you had lots of stories to tell us, and I want to hear some of these stories. So the question is, you know, the themes of this panel are data, equity, communities, as we've heard. To help us better understand how these themes converge, can you describe some examples of how data can be collected and used in collaboration with communities? And how do we need to think differently about this?
So now do I get my half an hour? I'm just kidding.
Not quite.
I would take it. And I don't want to just ignore the fact that we just had like a really provocative comments. Dr. Siddiqui like really challenged us. And these are the kinds of things I think about quite a bit actually, so I'm gonna. Can I also address that a little bit in my response? So I think that community engaged research is a thing on its own. You know, like we're drawing on ideas around like community-based participatory research. We're drawing on knowledge to action kind of frameworks. Like that's the kind of thing that community engaged research gives us. When we think about health equity research, it doesn't necessarily mean community engaged research, but there's a really important distinction between health equity research and the sort of methodologies and perspectives that draws on, and Indigenous research and the methodologies and perspectives that draws on. So I think that this is one place where I often am challenged if I'm on a panel around equity and community in general, and I'm asked to answer a question around equity research or equity, when really like my focus is on Indigenous research and research that aligns with the principles of Indigenous sovereignty and nationhood. And that's quite different than even community engaged research. It draws on those things, and it also is distinct from health equity research, because one of the things I noticed in the panel is there was no, like when I was talking, I didn't compare Indigenous communities to other communities, and I didn't say, look at all the inequities, because that is not drawing on Indigenous methodologies and perspectives, where we're doing that sort of thing that we do in health equity research, which is compare and try and highlight inequities. So community engagement in use of large data sets at ICES, for example, has helped me to see that Indigenous communities are not interested in us telling stories about inequities in health outcomes without addressing structural inequities. So there has to be that action in the research. There has to be and we can't just keep telling stories of inequity. We can't just keep highlighting inequity. So like, it was helpful that you showed examples of things like probably lots of research that's been done in the past has done enough to highlight inequities that then we need to address. And so these are the kinds of principles that I'm drawing on when I'm thinking about community engagement in the research that I do with Indigenous communities, because there are times where they want to show deficits and difference and inequities, but that's for them to understand where the next best steps, what do we need to do. But it helps me to move away from the idea that descriptive research that compares Indigenous and non-Indigenous populations is the goal. It also like getting to more like technical things. Like if we were doing non-community engaged Indigenous research, we would be defining things completely inappropriately. We'd be defining outcomes that aren't important, that aren't valued culturally or historically. And so in the context of communities. So it's one thing to say we need to like close gaps in health outcomes, but where do communities want to go? There has to be some element of that. Maybe it's not closing the gap, maybe it's further. So we need to be like thinking about the gap differently. And then the last thing I want to say, and I didn't get to tell the stories, but the last thing I want to say is like, even things, or maybe I'll tell one story. So one of the ways that we've used the data at ICES, so that platform has been built, and then communities, there's a collaboration of communities across Northern Ontario called Mamo Ayamoan, which means everyone's voices. And they access the data to tell their own stories. And they are comparing, they're doing comparisons, but they're building the stories. And the last big analysis they did was around mortality. And the way that they saw that data, in the spirit of that data, the title of their report was called Listening to our ancestors, because the data represents people that are their family members and community members who have passed on. So it's that like spiritual aspect of the data as well in using the data. But technically, working with them, it's helped us to refine our definition of on and off reserve. So like there's all these layers to the community engagement. It's the meaning of the data, it's the questions we ask, but then it comes even down to, okay, if we just use our regular algorithm to define on and off reserve, we're going to end up making mistakes in these communities. So we need to refine that. And we would only be able to know that we're doing it wrong if we're working together. So these are some of the things I think are really important when we're using large data sets and we're trying to tell big stories, that that doing it in collaboration means we're asking the right questions in the right ways, and that there's that we're doing less harm than we could otherwise be doing.
So much. You spoke quite a bit about the distinction between health equity, community engaged, and Indigenous-led research. Arjumand, just because this was a response to the end of your talk, do you have anything that you want to add?
No, just that I really appreciate that distinction, and it's not one that I can sort of knowledgeably speak to, but I really appreciate it. If we were to go to the health equity component of it, the one thing I would say with due respect is I don't think it's helpful to think of the literature as solely descriptive. I think the scientists I showed would take deference to being told that they're doing just descriptive work. They're actually doing a lot of causal work. The other factor is that I think what you said is definitely a sentiment I hear, which is enough already. We know now we got to do something about it. I don't think that's actually the case. If you think this is an important scientific question. It's like asking, it's like saying for anything that's been studied for a long time, do we know enough? Do we know enough about cancer? Do we know enough about diabetes? We've been studying it forever. Surely we know enough. But we keep learning. That's what science is. And we keep understanding, for instance, how inequities respond to different social conditions. So we're learning now that, the social determinants of health framework is a little bit falling apart in our ability to explain not why health inequities exist, but why they are increasing over time. Why, for a time, white mortality in the US was rising when other racial groups was not. There's other determinants that we're learning about that we didn't really pay attention to that have to do with the current populist political climate. So again, this is my point. I mean, yes, I don't disagree at all about the benefits of community engaged research. My question is, and obviously my personal orientation to this is that if you treat this also like a living, breathing body of science, that there are some fundamental science questions that need to be sort of explored, and you need the sort of perspective that this is not ready for prime time. It's not ready for intervention. But if you don't think that, which I think a lot of Canadians do not, they don't think that health equity is the realm of fundamental science, and that really mostly what we should be doing is saying we know enough and let's now work with communities to do action. And so I'm assuming that means the research is research on action because we know enough. So then we don't need to do any more research of any other sort is kind of the takeaway. So I'm being a little glib, but that's because I think that's actually the prevailing sentiment. And that's what I'm kind of pushing back against personally, is I do think there is fundamental science questions, and we're experiencing that in real time.
We have an in-person question, so would you like to go ahead?
Sure, thanks. So it's actually a question for Arjumand, but obviously others can jump in. So I'm curious, it sounds like you're making a bit of an efficiency argument. It's possible to do more basic science and explore different types of questions in this not engaged way because it's kind of easier in some way, and that there's lots to be learned, and this is a whole basic science. And I'm just curious, so maybe I'd like you to unpack the argument. Is it an efficiency argument? And you talk about, you can get into sensitive topics. So historically, there's a whole body of research on IQ and race that, was, I guess, done in a way that's not engaged and used to various effects. And just, I'm curious, are we, what are the things that protect us from going down that route again? And maybe what are the risks and the benefits of this approach?
Yeah, it's a great question. I don't want to hog the panel, though, so I'm going to be really brief. It's not just an efficiency argument, though there's no question there's an efficiency argument there. If you look at the work of Nancy Krieger, of David Williams, the prolific nature of what they're able to produce, there's probably no question that part of it is because they're able to just go at the data. It's publicly available. They can assemble teams and go to it. But it's not just that, it's also a political orientation to the problem. The issue is that there are politically sensitive topics, there are scientifically important topics that aren't going to mesh with communities' real-time needs. So if I want to study the epigenetic effects of racism, I don't know, maybe there's a community out there that's interested in that, but that's probably not front of mind for them, and yet it's really important for us to know that that's happening. And it's not just important to know in and of itself, but the very reason we've learned that racism affects epigenetics and sleep and behaviors and physiological stress, and I could go on, is the very reason we know it's a fundamental cause that you can't downstream intervene on. It's precisely because it's not just operating through one or two pathways that we've now learned the importance. So ironically, the epigenetic work is what tells us that the upstream structural change is what's needed. So there are multiple ways this plays out. Now, can I guarantee you that bad science doesn't happen? No, but I don't think I could guarantee you that even if it was community engaged. What's to tell me that there aren't community groups that subscribe to really problematic, orientations to race, ethnicity, class, et cetera? Nothing. So that part of me actually wonders, are you letting people sometimes get off because they're from the community with no checks and balances there? I worry about kind of the opposite.
Thank you so much for that response. So I'm going to do a question to Paula, then a question in person, and then one to Peter. So Paula, although sex and age data are typically collected in research surveys and in clinical care, why are statistical analyses looking at the interaction of sex and age often then overlooked?
I guess that's a bit of the million-dollar question, right? Because as I've said, that information is pretty bare bones and it's collected in just about everything. But I think somehow people don't see or don't link perhaps why it's important and why it eventually kind of impacts clinical care. I remember looking after, there's a lot of spill-on effects. So for example, as a geriatrician working in long-term care, we looked after a lot of older people, most of whom were women. And one of the things we started noticing early on are real sort of practical, perhaps, impacts of not thinking about these things. So as it related to drug prescribing, as an example, started noticing that older people would be getting doses of drugs that they clearly weren't able to tolerate. And those were the recommended doses. And we would have to then go back and think, okay, well, maybe the pill needs to be given at a smaller dose. And so just to manage that, we'd start having pills split and giving people the lower doses of pills. I started seeing that kind of thing in my own sort of clinical observations. But then we were able to look at a larger level and look at what was happening, for example, at an organizational level in long-term care, and realize that what we were seeing wasn't just a one-off, it was affecting many, many people across the long-term care homes, like more than a third of residents, as an example, every day having to get their pills split for a whole variety of different reasons. And then using data from ICS, seeing that some of the very commonly used pills for older people were being split by hundreds of thousands of people every day because that's the doses that they need. But that goes back to the idea of sex and age, that if you don't think about potentially people that are impacted, so for example, older people that are more likely to use pills, and thinking about them and thinking about maybe, what might the dose be that's appropriate for that group, or recognizing that perhaps side effects are greater for women than men, and factoring that in, you miss it. And it all sort of filters around and has clinical implications, so important.
Thank you very much. I'm just going to go to the question that we have in person. Please go ahead.
Okay, great. Thanks. Mike Green from Queen's University and the Inspire Primary Healthcare Group, which is part of OSU. First, just had a comment, I think, around the fundamental science versus community, which is, I think, my challenge is who gets to define the difference and how do we decide where that line might be? And maybe that means a broader think about what's community. Community means one thing at a small, definable community level, and maybe something else at a population level of who you engage with. I think I've learned a lot from Jennifer over the years about these layers of community engagement, so that would just be one. The data question I have is for Peter. Language concordance is really important, but has been really hard to study because of poor data quality also. So I heard your comments about bringing data in. I think it's just physicians. Healthcare system is a lot more than physicians. And I know that as an ICS scientist, it's been challenging because we don't get a lot of comprehensive data always from our professional organizations about our providers and who cares for patients. So maybe if you have any thoughts about what's the responsibility of professional organizations to provide that kind of data for Linkage so that we can do this sort of work?
Yeah, thanks, Mike. And that's a great question because it took us a while with CPS for them to give us the data, And we're actually working through the same process. I agree, like physicians are physicians. I think there are a lot more healthcare professionals. Obviously, us not capturing the other healthcare professionals that are involved in care, like nurses, would attenuate the results, right? Because it would miss some people who did actually get language concordant care from the nurses, for example, right? We're trying, so the next thing we're trying to do is actually bring nurse data. Uphill battle. No one wants to give us the data. We asked, RNAO, can you please give us the data? There's sometimes a mistrust, right, of what you're going to do with the data, because when you link this data, for example, the physician-based data, not only can we look at characteristics that are obtained in the CPSO, but we can actually study physicians as patients. And so we've been able to look at things like physician suicide and self-harm, to physicians practice what they preach, those kind of things. And it can be quite contentious, right? So we're trying to do a project on physician mental health and how it impacts practice. Like, wow, is there a point to that, to get to Jen's point, I think it's kind of like the so what, can you do something productive with it, and can you not only look at disparities, but actually, promote things that are constructive to the issue of the inequities that are at hand. I forget what your question is, Mike, but essentially, there's a lot of gaps, right, in data, and it's a struggle. Like, it's a struggle, and I think Rob Reed is here somewhere as well, but we're part of the Ontario Health Data Council headed by Jean Philpott, and one of the issues we're trying to address is, how can we break down these barriers so that we can link data in a more seamless way, in a structured way that doesn't, make us obviously go one by one with partners, right? And have those discussions over and over again.
Paula, I think you had a response?
Yeah, I think that's such an interesting question. And I mean, clearly it would be great to have language data. I mean, that's a really, really important piece that we kind of overlook. But I also think because it's hard to get that kind of data, we also need to think about what are some other ways that we might be able to kind of approximate that kind of information, and starting to think about what other variables or whatever things are already collected or available that might be helpful. So for example, something like immigrant status or something might give you a clue. Not great and not perfect, but maybe it allows you to start in some of that direction, because it's very hard to bring in some of these new data sets that you'd like.
Yeah, and some of the data is there, but it's not, it's not connected, right? I think some people at ICS, I don't know if people on the table around here are trying to bring in language data from OHIP that's collected, right? We know the language of every single person, right? What they speak, language you speak, it's not connected, So there's lots of work there as well for data that's actually already there as well.
How true.
And then, hey, Walter, how are you? I think you have a question.
Nice to
Please
see
go
you,
ahead.
Thanks, everybody. I really appreciate the comments this morning. And I am a health services researcher, use a lot of the data, and I struggle as to whether and when to include community and which communities, and I do a lot of work at the population level, so there are many communities in the data. Do you have a reflection on how to think about how would I know if I'm engaging community well? If I'm looking, say, for example, looking at the population of Mississauga, which is something I do, and trying to understand whether we're meeting the needs of the people with mental health illness in Mississauga. I'll give you something concrete to think about. There are Indigenous people, there are Black people, there are women, there are young and old. How would I know whether I'm engaging those people appropriately?
Yeah, that was one of my questions too, because communities aren't siloed. There's lots of intersections. And so how do we address that? Does anyone want to take this one? Can I see a hand? Or I might call on somebody. Anybody in the room? Maybe I'll see, I was going to ask this question originally to Arjumand, so maybe I'll pick on you and see if you had a response.
I'm sorry, I don't really do a lot of community engaged research, if any, so I don't have a good sense of the answer to that. When I do engage, it's usually with policymakers because I study structural conditions.
Jennifer?
Yeah, so this is a really important question. I haven't done work with like a whole city, like that kind of approach is different to me. But I think that one of the ways that it's like, advisory groups, things like that they're helpful in some ways, but also can be kind of problematic, right? Because you don't want to have one person representing all the women of Mississauga and one person representing all the, that's not how that can work. And it's often hard to recruit people to these overall advisory groups that can actually direct the project in a meaningful way and include those perspectives. So I guess I'm first just kind of saying an advisory group can be helpful, but can't be the only way that we work. And I just wanted to pick up on one of the points that Dr. Siddiqui made, which was, so I've worked with groups before where there's like a patient, like large networks, and there's like a patient advisory group. I presented once to a patient advisory group for a large network about Indigenous research, and there was a very much a tone of enough Indigenous stuff, we're tired of Indigenous stuff. So the point you made about there could be embedded, racism in a patient advisory group is true, right? So we do have to be quite cautious about the way that we do this. So in my experience, engaging at different levels, but using connections and relationships with community organizations has been most effective. so that it's not so much, okay, this researcher sitting at the university or sitting at ICS or sitting wherever they're sitting has to now create this whole network that represents Mississauga, but rather like having engagements with community groups that are already part of the social fabric of a community is probably the better way to go. In the end, then, you have to do some balancing out and weighing out of different perspectives, but that's the hard job of community engaged research. So I would say, like, you hosting an engagement session, you'll probably only get a certain kind of person. But if you're working with community organizations who already have networks, who create that fabric, then that's often a more effective way to go. And it can't just be, you know, like a panel advising one time. It really is an ongoing process. So those are some of the things I would say, but also there's not a formula, right? And it's going to look different in different situations, in different projects, and with different research questions.
So I think validation that it is an issue and a question that begets further discussion. Any other comment, Walter? Okay, so we had, I think, one more in-person question. Frank?
Hello. I'd like to ask about data gaps, especially from a sort of a patient and public perspective. Dr. Zahn talked about the importance of like going upstream, you know, the earlier the engagement. So maybe the question around, we have a paradox that we have more and more data, which might suggest, you know, we're covering everything. But I'm just wondering if, you know, where the engagement with patients and so forth to identify important gaps. So, for example, I'm the chair of the Public Advisory Council for the Health Data Research Network. And we had a group where we had a woman from England talking to us, for example, about, you know, miscarriages, for example, and how many are not reported and so forth. And she was talking about, you know, that, you know, and with, you know, if for a patient might assume, for example, that telling your family physician about a problem you're having with a drug, an undesired side effect, you know, that's reporting it, and that, of course, the physician may not report it at all. And if you've ever tried to report a side effect on the Health Canada website, it's really, really difficult. So that gets unreported. And when I was on a drug committee once, we had a lot of data, tons and tons of data about the cost to the healthcare system when we were doing an economic analysis, but almost no information, no data about the cost to patients and families of, you know, whether lost school days, lost work days, you know, all sorts of other missing data. So I guess the question around, and it seems to me that you have to have sort of thorough early engagement with, and where there's trust, so that where people are able to identify early on, you know, what's important to them. Are the right things being counted, measured? So I'm just wondering, you know, what we're doing to look carefully at, and who's responsible, can we, for identifying the data that are missing, and who's best positioned to identify what that missing data are? Lots of questions.
Yeah, that's a big one for sure. But maybe, Peter, I was going to ask you about sort of what data we're missing and upstream data collection. So I thought maybe you could comment. I don't know, Charles, too, if infrastructure you have comment, but maybe Peter, we'll start with you.
Yeah, I was going to say Charles can answer that question. He's responsible for finding the gaps. I mean, there's so much gaps, right, in health, but like, I don't know, like, how do you prioritize things, right? Like, I think it's true, we're nowhere close to, I think, you know, doing all of the science, you know, that needs to be out there. I'll just give you a quick example. You know, I think one of the research we're doing right now is looking at nursing homes and, you know, language concordance and ethnic-specific homes, right? I had a patient who was dying, for example, and he clearly needed to be in a nursing home. He was a Chinese man, and he told me, I do not want to go to a nursing home because they do not serve rice every meal, and I eat rice every single meal, right? And in Ottawa, there's no Chinese homes, no ethnic-specific home. And, you know, that data is there, that data can be mined, we had to go out and collect that data, with that intention in mind to kind of solve that issue about, providing care that's ethnic concordant. And I guess where I'm getting to it is sometimes it's responsibility of us, collectively in the room, who have these questions that we're trying to solve and policy issues that we're trying to, improve on. And for us to make sure that there's a clear link to the so what, right, and collect data so that there's clear outcomes that we're trying to affect. So for example, the language, I showed very descriptive data, but that data, we presented in Quebec to help, the French language laws, right, that you have to, you will receive French services, 6 months after you land as an immigrant, right? So we said, well, yeah, you can do that, but you're gonna kill people, and there's consequences to that. And I guess my answer is who's responsible is, I think it's obviously collectively all of ours, and that includes the scientists that are here and the researchers that are here to try to kind of find those data gaps and work hard at trying to migrate that data into your research programs. I'll start there and pass on to Charles.
Yeah, Charles.
Yeah, I agree completely. The researchers, the scientists that understand where the gaps are, what they can't study. But this is where community engagement, in my view, is helpful, because the community engagement helps inform the scientists in terms of what we want to look at, what should be looked at, what's important to community, and then we identify where those gaps are. The one piece of data, or many pieces of data that I think is so rich and so important that we have to do a better job at integrating and working through is the primary care data. That data is extremely rich. Miscarriages are probably recorded in the primary care data, but it's in a text field. It's not codified somewhere, so we need that fulsome data to come in. But we need to spend a lot of time and some pretty fancy methodological techniques to work with that data to be able to identify those outcomes that are important to patients, like miscarriages, just to choose that as an example.
Thank you. Any further comment?
Well, just sort of thinking that, it's going to be pretty hard for us to ever anticipate what are all the different kinds of data that we want. And I'm always impressed by when you speak with patients and you ask them, really what matters most to you. The kinds of things you hear are not necessarily what you expect. And so it's really important to remember to ask people as a starting point.
Well, you guys, I'm so sorry. We've come almost to the end. We're sort of at the last 2-minute mark, so I don't think we have time to take another question. I'm so sorry.
So it's not a question, it's a comment and a response to
Sure,
some
go
of the
ahead.
questions that have been asked. So my name is Bilkis Williams. I'm the chair of the OSU Sport Patient Partner Working Group, and I was hoping to respond to Walter and his questions, as well as comment on some of the panelists' speeches. So Walter had asked when was the best time to engage patients, and it's always at the conception of research study. So at the moment you're thinking about it, that is the moment that you need to engage patient partners, so that those questions that Dr. Ashon is saying will pop up, the relevant questions that people really need the responses to, and so that will help guide the direction of your research and also help it to be as rich and intuitive and also as productive as you wish for it to be. Also to help your process to be more effective, because you're working with people who really know the run-ins of things and you're asking the right questions from the right people and the right quarters. Also, another way that you can improve the efficacy and the outcomes of research, especially in the application in real life, is to train patients in engaging with researchers, which is what the OSU PPWG group does. So we provide the facilities and resources for patient partners to be able to engage with researchers on a level where everyone knows what the consequences are, or what the conversation is as well, and everyone is at par when they're conversing. So it's really important to let patients know that they have power, to equip them with the ways in which they can report some of these important conversations that will further direct research in the right path. And thirdly is to always engage the patient at the conception. Oh, last thing, this organization is going to say I'm always plugging them, but there's an organization that exists solely for the purpose of directing the researcher and the patient partner in the conversations that are going to be useful, and their name is Amplify Engagement. They find the people that you're looking for and the communities that you're looking for the questions that you're looking to answer. Thank you.
Thank you very much. Amplify engagement. Amplify engagement is what she mentioned. So I can't think of a better way to wrap up this panel than having it close with a patient partner. So I just want to take a minute to thank our panelists for their insights. Can we give them a round of applause? And I think we kept pretty close to time. All right, great.
Hang on. Great. Thank you, Seema and panelists, for engaging and respectful discussion. I think it was a fantastic session. And it's great to see how the patient-oriented data researchers, infrastructure can have an impact and potential impact on the health of Ontarians. And actually that session demonstrates how OSU is well positioned to help Ontario's health research community to generate high value and evidence to support policy and decision making. And I'd also like to note that our community, our OSU community, is very broad. It includes the SPORE chronic disease networks, one of which, Childbright, you'll hear about today, from today, the SPORE Evidence Alliance, the SPORE Canadian Data Platform, which we heard briefly, the SPORE National Training Entity, and many other SPORE initiatives, the Innovative Clinical Trial Initiative and other program awardees, all are working in Ontario to produce valuable evidence to shape healthcare. And of course, all of this work would not be possible without the support of the CIHR, the Canadian Institutes of Health Research SPORE program. We're lucky to have its Executive Director, Amy Lang, here join us today, and our funding partners, the Ontario Ministry of Health, Sick Kids Research Institute, the Ottawa Hospital Research Institute, Hôpital Montfort, and the Institut du Savoir Montfort, St. Michael's Hospital Foundation, and the CHIO Research Institute. All sit at our funders table and provide fantastic input there. It's now time for a break. We'll break until 10:50, and then we'll start again with the session on the learning health system. Great, thank you.